Just 2 more seconds, sir. Yeah, start, Dr. Junaid. Just 2 more seconds, sir. Dr. Junaid, you can start. Yeah, start, Dr. Junaid.
Yeah. Can I start, Dr. Hossia? Hello?
Yes, doctor. Yes.
Yeah, thank you. Assalamu alaikum, everyone. And good evening. Dr. Junaid here from Aina Wellness Center. And I would like to thank Dr. Hossia and the members of GTP for giving me an opportunity to speak in front of you all. And I would like to thank you all for being a part of this wonderful session by Dr. Mueez, who is a wonderful orthodontist. So today's topic is orthodontics from general dentist perspective. So just as you are already aware that a general dentist is a dental professional who provides wide range of services to improve and maintain patients' oral health. So the scope of work for a general dentist varies from scaling simple extraction, simple restoration, crown preps, and preventive dental procedures. Of late, general dentists have augmented their work. They are doing advanced surgical extractions and advanced root canals, and then they are into implantology and other advanced dental procedures. So, as you know, dentistry is a business of smiles, and when you see a person, you just look at a person, and you just first thing which is catching is the smile, and other things follow. So, the elements of smile include color, shape, size, and alignment of teeth. And when you talk of alignment, orthodontics and orthodontists play a very important role. So orthodontics is a dental specialty that focuses on diagnosing, treating issues with teeth and the jaws. So modern orthodontics include three-dimensional diagnosis, use of mini implants for anchorage, and use of self-ligating brackets to increase its efficiency. So today's topic for Dr. Abdul Mueez is very interesting because it is focusing on the general dentist, because we general dentists are focused on treating other specialties like surgery, endo, and smile designing and other things. But when it comes to orthodontia, we just stay back. We just immediately, when we have a patient who comes with a dental orthodontic problem, what we do is we normally directly call an orthodontist, and after that we are just a spectator in that. So Dr. Abdul Mueez, who is a very well-known orthodontist in Bangalore, who has done his graduation from Government Dental College and Research Institute, Bangalore, and did his post-graduation from AMES, Raichur, and presently he's associated with Shifa Hospital, and he's even taking care of some administrative works, and he's a consultant orthodontist for many dental clinics, and he does practice general dentistry. So he will be giving us a clear picture of things on what a general dentist will be doing when he encounters or when a patient walks into a dental office with some or the other minor to major dental problem, he should not uh, like call a orthodontist and then coordinate with the orthodontist, but he will give us all the approaches what a general dentist has to do. So Dr. Abdul Mueez, let us hear from Dr. Abdul Mueez because he's a pro in this subject, so he can take over and then explain the situation. In the end, we will be having a question and answer session. So you can just jot down if you have some questions, and then we can just discuss with Dr. Abdul Mueez.
Thank you, Junaid, for that wonderful introduction. It's really a pleasure, speaking to this audience. And the thing is, like, I'll be just talking about in my presentations. Like, I before I start my presentation, I would like to thank Dr. Hosia ma'am, like, who's behind, is the brain behind all this, conducting webinars, seminars, and then putting some questions in a global dental platform, so that some active interaction is there. And then with this interaction, like, I being an orthodontist, like, who was away from my general dentistry for about four long years. After, going through the cases in the GDP, I have started practicing endo, and I've started practicing, trying to venture into many things, like, because of this. So that is like the best part of this GDP, where, they encourage, and at the same time, like, they are the teachers and they're the mentors, and at the same time there'll be some leg pulling, which actually makes you and groom you for to be a good professionals. So sometimes because of your critics, sometimes because of your like, either by acknowledging it. So, like, we at the nutshell, you learn it, and then, like, thereby it improves your profile, whatever you are. Coming to the topic, like, my topic for today is, like, orthodontics, based on the general dentist, for general dentist. So my basic idea for this is, hope, like, my slides are visible. Are my slides visible?
No, they're not visible, Muiz. I think you have a share button in the bottom. You can just click on that share button, I believe. A green color button.
Yes, I got it.
Yes.
Hope
Yeah,
it
yeah.
is now.
Yeah.
Okay.
Yeah.
So this is my topic, like, orthodontics, general dentist perspective. The basic idea for choosing this topic for this gathering is, like, before you invite an orthodontist, and if you're practicing orthodontist as a general practitioner, probably for small cases, or like you're doing more major cases, and before inviting orthodontist for that specific case, at least you should be well versed with what you are going to say to the patient, like, what you are, like, it shouldn't be like, like, my as in when the patient walks in, it shouldn't be like, my orthodontist will speak to you. No. So based on few things, you should be confident enough, feel like you should able to catch up, or pick up few diagnostic stuff, where you can confidently, say the patient that, yes, you require so and so treatment, and you require so and so problem, this so and so problem is there in you. So this is what I thought, like, I should discuss for this gathering. So I'll be discussing my talk under this following heading. Like, how to go about in a problem oriented approach, like, what should be the, like, if there are, like, various problems, what should be our solutions, and how to go about the diagnosis and formulating the treatment plan. So in diagnosis, what all you need to see as a whole, like in a macro aesthetics, in a mini aesthetics, and then in micro aesthetics, And then and I'll be just covering it up. I'll just talk a brief about the smile and its component. Okay, basically our whole thing, as a dentist, as a doctor rightly said, will be our main focus will be on smile, and smile is one of the component as an orthodontist and dentofacial orthopedist. Like aesthetic is just a part of an orthodontic treatment. Trust me, it is like much more than that. It is it has the function, it has got a stability along with an aesthetic based on the Jackson track. So I'll be just telling you briefly about the extraction and expansion. How can we see our patient as and when they walk in that this case might go for an extraction and this case might go for an expansion or non-extraction, in other words. So this I'll be telling you in brief, and then followed by that, I'll be showing you few of my cases in a case series, and then finally conclusion, and then we'll sign it off. So to begin with, diagnosis in orthodontics requires a synthesis of manifold factors into a discrete list of problems, each defined so clearly so that the plan of treatment becomes evident. So as such, diagnosis is defined as an act or a process of identifying or determining the nature of the nature and the cause of the disease or injury through evaluation of patient history, examination, and review of laboratory data. One second. The goal of diagnosis process is to produce a list of individual patients' problem, taking into the account of subjective as well as the objective findings. The treatment plan is a connecting link between the diagnosis and therapy, in which the orthodontist establishes a blueprint or a work plan for resolving their problems. Essential to the establishment of a complete list is the creation of adequate database. So then now the current concept of diagnosis, and then the thing is, first ideally it was during Angles era, it was like more of about occlusion. One should have a proper occlusion, like cusp to cusp fossa, and then Angles class 1 molar relation, midline should match this. No more than that, yes, this also is important to get a good functional function to the patient. More than that, no, there is a paradigm shift of it's more of about soft tissue. So according to Prophet, the orthodontists have presently he views more on soft tissue than on the hard tissue. Yes, hard tissue also matters, like getting class 1 in and with a job basis is as important as soft tissue. But the main thing which is seen by any a layman or an outsider or socially it is acceptable is a soft tissue. If you have done like a fairly good job maintaining the soft tissue profile, then you have done something to the patient. So orthodontists have traditionally viewed the hard tissue structure discrepancy as a major limitation of treatment. In reality, the soft tissue that is more closely determined therapeutic modifiability. The new paradigm is nowhere diminished the efficacy or value of the orthodontic treatment for most patients. It may challenges the long-term effectiveness. The boundaries of dental compensation for an underlying jaw discrepancies are established by several aspects of soft tissue relationship and function. No, what is that like as and when to know the problem, you need to have a basic criteria. I mean, like the basic stuff, such as you need to record the case history, take do the clinical examination, prepare a plaster study model, and then you need to have a basic stuff, basic radiographs such as periapical, if it is any endodontically endodontic case, or a bite wing, and a panoramic. Basic is panoramic radiographs and facial photographs. All this thing constitutes a basic diagnostic criteria before identifying it, and then before saying the so and so problem existing, before coming out with the problem list. So as and when the patient walks into our clinic, first what is that you have to do? First, you have to record the history. why is that they have come for, and then their clinical examination. Probably the patient could have come for midline diastema, which is like more evident for it, for him or her. But as and when you open her mouth, like you are seeing that there is some high frenal attachment, and you are saying that there is macroglossia, and you are saying that there is high arch palate. As a result, there is a posterior collapse bite or a cross bite. So in that, patient does not know this problem what they have come for, but they just want the spaces between the teeth should be closed. So first you need to do a proper clinical examination, take the history, and while taking an history, history taking also is like you need to record the demography of the patient, whether the patient where they have come from. If at all, if the patient has come from for example, if they have come from any places such as Kolar side or an Andhra side, probably this patient are more prone for fluorosis. So you need to take in consideration of all this factor, and if at all, and then about the place, and then regarding few places where that is endemic, especially like fluorosis is very endemic in those areas. So that also we need to be considered. And diagnostic records, yes, like basic records such as OPG is must. And then along with that, if at all, if you see that there is jaw discrepancy, you need to have like lateral set as well. OPG, what is the significance of OPG? OPG, it actually helps in identifying the gross stuff in the patient, be it be it in a dental view, or in a bony view. In a dental view, you can make out whether there is the resorption of the bone, if there is periodontally affected bone. You can know the position of the tooth. You can know, and along with that, like there is like if there is a problem of a wisdom tooth, and then you nowadays most common is the TMD problem. So you can assess the bony condition of a temporomandibular joint as well. So based on all this, you have to have a database where you need to record it. Okay, like this patient has come with so and so problem, and this is the thing which we have found it. And based on database, you need to identify the problem list. Probably in the problem list, first thing is patient has come with as I was talking about the midline diastema. Patient 3-6 and 4-6 are it requires it's a DCPI, dental caries with periodontal involvement. The first and foremost problem is like you have to clear that problem rather than venturing yourself into an orthodontic treatment. First, you have to do the root canal treatment. If at all, if one of the tooth is periodontally compromised, that you need to focus on. Then, like if at all, if the patient has got fillings, or like if the calculus is C++, that requires a oral prophylaxis. All this, once the problem list is there, then like all this component becomes an important. Coming to the last, it is the orthodontic problem. In an orthodontic problem, first you have to prioritize what the patient says. Like the patient has got a problem of midline diastema. Yes, that becomes a priority. You might have picked up that there is a posterior crossbite. Patient is least bothered about it, but as a whole, that problem, whatever the patient says, becomes a problem number one, and that has to be solved. And then along with that in priority of the problems, you have to prioritize. Then next comes jaws, then next comes the teeth issues, then next comes habits. So similarly, if we start like with the problem, and then towards the particular solution, and that like that solution have to be dotted down in the paper. And in my practice, that's how I practice. So, like, but I say that, like, if the patient says, "Doctor, I want something, like to do this, that." No, first I prioritize it. I hear what all the patient says, then I come up with a treatment plan. Immediately, like I don't come and then directly bond the patient. So you before as and when the patient comes, you have to spend at least 10 to 15 minutes with the counseling, with like what are the types of braces which are available in the market, and what is the problem is the patient is having. And at the same time, you don't have to show them the skies, and then you have to floor the you have to get them to the ground, and then their ambition, their expectation. Somebody might be expecting something like I want the that particular stars like smile and all that. No, whatever the teeth is they have, like which we are going to do it. So like you have to get their expectations to the grounded level. So once like you have the priority order, then you are going to go ahead with the patients and parents input. You are going to discuss this. Once that is done, like informed consent. Informed consent in an orthodontics is very important, because with the informed consent, you can avoid the futuristic problem. So I in fact suggest all the general practitioners who have their own clinics to prepare an informed consent, especially for an orthodontics assets, like how you prepare for an impactions, or how you prepare for fracture reduction, how you prepare for extraction. Similarly, you should have an separate informed consent for an orthodontist. Then treatment plan concepts and treatment plan details. Last but not the least, financial part also needs to be discussed, and how the treatment how you are going to charge them, in what way you are going to charge. That needs to be discussed. Now, while developing a problem list, first thing like what you are going to see is the profile and aesthetic. In profile, as and when the patient walks in, you have to keep an eye on the patient. Like, it should not be like, when the patient is like talking to you and you are with your phone and you are doing something work, you are writing some other prescription. No, it shouldn't be like that. As and when the patient walks in to your clinic or your setup, watch his or her gait, watch his profile, watch his smile lines, watch his nose, and look out for his lips, look out for his eyes. So all this is important. In a profile, what is that you have to look, like whether the patient has got a convex or straight. Convex, it is seen in the class 2, straight you get in class 1, or in a concave in a class 3 profile. And whether the patient has got an asymmetry, whether the asymmetry is like skeletal asymmetry or a dental asymmetry, whether the facial proportion is good. Sometimes vertical height in the vertical height will be increased. Because of that, like he or she will have a gummy smile. And all this, when you are doing a conversation with the patient, all this has to be noted. The next one, as and when you take him to him or her to a dental chair, you have to see for a crowding alignment, whether in an alignment, whether there is a spacing or a crowding, or both in the upper or lower arch. In a transverse relation, you will be seeing about the crossbites, whether it is a skeletal crossbite. Sometimes it so happens that one single tooth will be in a crossbite. Okay, and sometimes it so happens that like the whole of the jaw will be in a crossbite. So this also has to be noted down or jotted down in your workup sheets. And then anterior posterior relationship, and this can be a class 1 molar, class 1 relation, class 2, class 3. That also be needs to mention, be it a skeletal or a dental. Vertical height, yes, like in a profile itself you can check it out, whether it is a deep bite or an open bite. All this has to be checked. So the what will be the when the patient walks in, he or she will have a three things in his mind. First thing is impaired dentofacial appearance. First, what does the patient say? Doctor, my teeth are very much forward. Sometimes youngster says like my teeth are buggy type. Few patients says like as and when I smell, I keep my hands over my mouth. And few patients will have different things. You have to, in a chief complaint, you should write down like whatever the patient says in their own language. Sometimes patient says like I cannot able to bite on one side. Patient says like when I am smiling, my smile looks like a crooked. It looks like slanted. So all this has to be dotted down. And then sometimes I feel like I feel awkward to smile in the like in a social places. So this also like social well-being also needs to be taken care of. And few patients, they walk in with a pain in the joints. Like this, I'm exclusively talking about the orthodontics. A few patients will have pain in the joints. Few people will have clicking sound in the joints. Few people will have because of this crooked tooth, they themselves will point out the tooth which is in crossbite. Because of this, like my lower teeth is getting treated. It's becoming mobile. So like as it's a era for digital. Because of like internet usage, they themselves Google all their problems and they walk into you. And then as like I already told in this thing, all this has to be noted down: medical dental histories, and then social and behavioral pattern, and then and then clinical evaluation, what all you need to see in the clinical oral health. and then check out for the mastication, how they are masticating it. I ask them to chew in front of you, and then ask them to open their mouth and ask them to close their mouth. Look for speech, if there is a lisping issue or not, and ask them if they have if they snow during the night time, if the attender is have come with the patient. So all this like basic things have to be noted down and jotted down before you call an orthodontist, so that like if you know the problem, what the patient is saying, then it becomes much easier for you to like that actually ignites you to go and at least ask your seniors, your orthodontist, like the problem the patient has come out with the problem, what should I say. So like in that, conversion of the patient becomes more when you yourself speak, and because the patient is coming to your clinic on your name, so it becomes like it is paramount that you know something about it. So like as I said, like if you start seeing all this, if you dot it down, if you in a piece of paper, it becomes much easier, so that like you'll know, like once orthodontist is making a conversation, you have to see like for this particular question, what did my orthodontist answer. So based on this, it becomes much easier. When you're I'll be talking about few things about the micro aesthetics. Okay, micro aesthetics, and then mini aesthetics, and then micro aesthetics. In this when you're seeing for a as a face and dental appearance, first thing which comes into role is the macro aesthetics. Our face, the facial proportion, it is divided under three planes. So be it asymmetry or deficiency can be made out by look of the patient, that comes under macro. Okay, and in the mini aesthetics, like it is mainly the dentition. You are going to see like what all I have discussed just 2 minutes back, that is dentition, your sleep, like all this whether it is a teeth or a gums, you are going to look for. And the display of the teeth at rest during speech or smiling, excessive gingival display, inadequate anterior teeth display, and then inappropriate gingival height, excessive or deficient buccal corridor space. All this you're going to see in this mini aesthetics. And in micro aesthetics, it is the teeth in relation with each other. That is the alignment. And you're going to see the assessment of height and width of the tooth, and then gingival contour, gingival shape, shade of the teeth, shape of the teeth, connectors and abrasions. I'll be discussing, I cannot, with this 40 minutes of talk, I cannot include everything. I'll just give you the gist of all this, so that like it tickles your mind to go and ponder over these aspects and then come up with a concrete solutions. And then the first thing is in micro aesthetics is like the first step of evaluating facial proportion is to take a good look of the patient, that which is just now discussed. And then looking too quickly, it shouldn't be like that's how, what did I say, like when the patient has come, it's not like when patient wants to speak and you are at the phone. When patient wants to speak, you are at calling your assistant for a tea, or like if you are asking them, you're offering them tea. No, that is not the thing. When you are with the patient, your whole and soul with that patient, because he has come with a lots of expectation from you. So looking too quickly, there are chances that you might miss out some of the bigger pictures. So facial in that, like in facial aesthetics, like what all you need to counter it is that vertical facial height and transfer facial height, and their proportions. Then along with that, like you have to see for the profile analysis how the profile is, like whether it is they have got a straight profile, concave profile, and that is convex profile, class 2 or class 3 or class 1. And evolution, then like about the nasal proportions also, whether the patient has got a pointed and a sharp nose, or it has got a blunted and then that nose. And then lip projection, whether they have a competent lip, or bulky lips, or then you have a thin lips. That also needs to be seen, and then along with that, you have to see for the chin projection, whether the patient has got lots of fat deposition in the chin, or the skeletal bone itself is so much, especially in class 3 tendencies, their chin will be so much projecting it out. That also needs to be taken care of. In a facial form, the relationship between the facial width and height has a strong influence on the facial harmony. The height to width proportion, that is from the trichion, uh, from this point, from this trichion to the menton, and then zygomatic width. So usually in females it will be 1.3:1, and in males, females, whereas in the males it is 1.35:1. Okay, and by gonial width it's approximately 30% less than that of this becomes more more. But I just wanted to focus you just look for whether the patient has got a rounded face, or patient has got a straighter profile, and then all his malar region is prominent, and skeletal features is prominent. All this needs to be seen in the facial forms. And in the vertical profile you just have to see in the 1/3 of the face. So that is upper 1/3, middle 1/3, and lower 1/3. And in lower 1/3 also there is equally divided, that is from the nasal base to the upper lip, and from the upper lip to the chip to the menton region. All this has to be you need to take them into consideration. If at all, if there is any defect in the upper lip, it is probably, usually it is not seen. If they are walking into they don't walk into your dental office if there is a defect in it. Usually it will be craniofacial anomalies, or it will be in a syndrome cases. If at all, if it is there, it will be there in a vertical maxillary access, or they'll have shallow cheeks, excessive sclera show and below the iris. They'll have a flatter cheekbones and a narrow nose. Whereas if it is decreased, I mean the upper 1/3 of the face, it will be like the cheeks will be full, chubby cheeks type, and they'll have a broader cheekbones and shorter base nose. Then nose will be very short, and then blunted one. So in the middle 1/3, uh, what all I was talking about is the middle 1/3. Middle 1/3 also it's not usually it will be in vertical maxillary axis. That is like the from the nose tip till the upper lip. So in this that's what I've been discussed. And the next thing is the lower 1/3 of the face. Lower 1/3 of the face is the maximum which you encounter it. In this, what you have to see is whether there is a vertical maxillary access or not. And then vertically maxillary access, usually you'll have a gummy smile. Their teeth will be projecting it out, and then they'll have an increase in the interlabial gap. They'll have an increase in the teeth show. They'll have an increase in the gum show, and they'll have narrow nose, narrow chin. They'll have a class 2 open bites and vertical mandibular access. Whereas if at all, if the lower 1/3 of the face is decreased, they'll have a decrease in the vertical maxillary deficiency. It will be there, and there'll be a little or no incisor show under the upper lip. So, and they'll have a class 3 tendency and vertical mandibular deficiencies. So in the mini aesthetics, there'll be two smiles. Okay, one is you have to record, you have to take the photos. In this, first thing is you need to ask for a social photos. Social smile is one when you are greeting somebody and you are meeting the unknowns. How you smile? You just greet and just you flash your smile. That's it. There is no social smile. In this, for an orthodontist, as an orthodontist, you need to know both the smiles. In a social smile, patient will be very what to say, very it is reproducible. It is a voluntary. It is a sign of a signal of an appeasement or attempt to indicate the self assurance. Okay, whereas enjoyment smile is imagine you're meeting somebody, your close ones, and then somebody has cracked a good joke or something where you expresses your laughter like anything. So that is an enjoyment smile. Both has to be taken into consideration. And this two things which has to be noted as and when the patient is smiling. So first thing is the incisor show, how much the patient is able to how much of the incisor is visible in the patient, and along with that gingival display. So how much of the gingival display is seen. So gingival margins of the canine should the gingival margins of the canine should be coincide with the upper lip, and the lateral incisor should position slightly inferior to the adjacent teeth. So okay, next thing is when the patient is smiling, that is the vertical thing which you see. you see the teeth, you see the gums. So what is the thing which you see in the transfer direction? You see buccal corridor of space. Buccal corridor of space is nothing but the spaces between the maxillary premolar and the inner portion of the commissure of the lips. So this is important because whether like this indicates whether like you can expand the case or whether you have to go for an extraction, whether you go for an extraction or a non-extraction. If there is a sufficient buccal corridor of space, you are going to expand it. If there is no sufficient buccal corridor of space, you need to go for an extraction. Next thing is you are going to see in an arch form. The narrow or collapsed arch, especially smile, also may appears narrow, which is less appealing aesthetically. If there is a collapsed arch, it will look very not very pleasant. If it is wide maxillary arch, like they say, what man, like you have got a full bloom smile. That is, you have got all your molars are visible. Like widened maxillary arch will have like even the molars sometimes. I mean, to be precise, second premolar also will be visible in a wider smile. In a narrow arch smile, it will just few teeth will be visible, probably canine to canine. That is called social smile. Next component of smile is the smile arc. What is a smile arc? Smile arc is a relationship of the curvature of the incisal edges, that is the incisal edges of all the teeth or the front teeth, that is social six, along and this to the lower lip. That is the curvature of the incisal edge of the maxillary incisor to the curvature of the lower lip in this in a social smile. So if the curvature of your lower lip is is parallel to the your incisal edges of our upper teeth, then it is called consonant smile arc. If they are not coinciding, if it is flat, then it is a non-consonant smile. Usually consonant, if at all, like smile arc, actually one of the most important factor which actually gives a pleasant look on the patient appearance, patient smile. And if at all, if you have established these features in an in the treatment plan, it really looks like the patient has not got his braces treatment done or an aligner therapy done. It looks very natural if you have if you have incorporated these features. And then transverse, in this, like what is seen is like the occlusional plane. Sometimes it so happens it can be because of a single tooth, okay, or it is because asymmetry of the vertical growth of the mandible resulting in the compensatory cant of the maxilla, or it can be gingival head. It can be because like whole of the maxilla itself is like its position in this way, or it can be because the incisal the curvature of the gums itself is itself like in one side, because the teeth was positioned in such a way that like the curvature of the incisor itself has gone, so it looks very prominent. As a result, it looks like the occlusion is canted. So this also needs to be considered whether the patient has got a skeletal canting, that is maxillary occlusal plane is deviated to one side, or it is because of the local factors such as the teeth positioning, or it can be because of the gingival head. So all this needs to be taken into consideration. Then coming to the microaesthetics, the portion and the shape of the teeth also of the teeth as well as the gum has to be taken care of. The smile reveals that. So in this microaesthetic, first thing you have to take in consideration is the golden proportion. Golden proportion is nothing but if you have seen the architectural things, old palaces and all that, it is based on all golden proportion. It is a phenomenon where like the front teeth is, if imagine if this is the visibility of the front aspect is 100%, 62% of them should be just behind this, then only it gives a symmetry and it comes under the golden proportion. So the ideal similarly in the oral cavity also, the ideal tooth width proportion when viewed from the front option should be positioned in that way. So whatever the central incisor are positioned, imagine this, if this is 100%, the 62% visibility should be there in the lateral incisor. From there, 62% should be there in the canine. So if we incorporate these components in the smile designing or in the orthodontics, the patient will have a lasting smile and it will be very attractive. And similarly, height and width also. If at all, if there is like this height, if there is an increase in the height, then teeth will increase in the width, then teeth will look more of squarish. and if it is increase in the height, to look like it will give a longer appearance. If at all, if there is a shorter clinical height, then you have to opt for an adjuvant therapies, such as crown lengthening, and then go for a passive eruption or a laminates before going venturing ourselves into the orthodontics. Then gingival height and the gingival height, shape, and contour. Even the proportionate height of the gingiva is also important. So sometimes the height of the maxillary, I mean the shape of the central incisor is almost half ellipse. Incisor and the canine. Where incisor and canine is half ellipse, whereas the lateral incisor is half circle. So this is also important in designing the smile aesthetics. And then usually what happens, if at all if the patient has come with a crookedness, they will develop something called as black triangle, which has been shown in the diagram. So in these cases, you have to detect, you have to before counseling, before giving the procedures, before treatment plan as such, you need to mention this aspect as well, that on closure of your spaces, imagine this is the case where the one has been overlapped by 2 1. So obviously when we have aligned it, we have developed a black triangle. This can also be minimized by doing some amount of IPR, interproximal reduction, and then closing the spaces. So this also taken into needs to be considered. And tooth shape and color, like this is especially when you are anger, and then you'll have a brighter teeth, and then as and when you grow older, like your teeth shade and color will be much darker. Usually the central incisor will be the brightest of all, and then lateral incisor will be lesser, and from canine it goes to the molars, and the shade gets decreased. Coming to the component of this, the first thing the patient says, doctor, I need braces. Second thing the patient says, doctor, are you going to pluck my teeth out or not? Third thing talks about the money, obviously. So for an extraction or an expansion, to say whether the patient requires or extraction or an expansion, many important parameters comes into consideration. First thing, the the spaces availability. Okay, in crowding, for example, if there is no space at all, and then if there is no space, probably we have to go for an extraction. And all the parameters which I have discussed prior to that, be it buccal corridor of space, be it the size of the teeth, be it all this comes into play now. So in general, if it is been decided that this patient will go for an extraction, so one thing you can get into the patient thought process, that after extraction the teeth will become less prominent. Without extraction, the teeth will become more prominent. So first and foremost is that. And in next subsequent slide, I'll be telling you, then it is necessary to discuss both pros and cons with the patient and parents before making the extraction or an expansion decision. For an aesthetic consideration, expansion of the arch moves the patient's direction to the more prominent teeth, while extraction tends to reduce the prominence of incisor. That is a known fact. And there will be an excessive lip separation at rest. While expanding, there will be probably, if there is no space, the teeth might jut out of the mouth. And then you need to see the nose and chin relationship. So as I pointed out while discussing about what all you need to see as an in the patient, in your clinical examination, nose becomes an important part. If the patient has got a prominent nose, then you can think of doing extraction. If the patient has got not so prominent, it is blunted in layman term. If it is a blunted nose, then it is always advised to go for an expansion. And for best aesthetics, the lower lip should be as prominent as chin. Patient with an excessive incisor protrusion and retracting the incisor improves the facial aesthetics. So this is how it is. If the patient has got a flat lips, okay, that is thin lips in our terms, what we say, if the cupid bow appearance of the lips is not visible, then we can think of an extraction. If the patient has got full bloom, lips, thick lips, then always don't extract. Otherwise, it will result in sagging of the lips. It will be, you're not at all going to do the justice to the patient. So it is always you have to go for an expansion. That is non-extraction. For a stable result, sometimes it is better if we extract. Relapse happens lesser. I don't say it is like, like by saying lesser word for an extraction in a relapse cases, I might create a controversy. But the thing, but still, like if at all, if there is a space requirement, in spite of that, like you are expanding and then you are strapping up the case and getting the clear thing. So they like the stability is really questionable if you are expanding it, but sometimes it is vice versa. If you have got a sufficient arch width, and then if you are expanding it, then yes, it is like you have done a fairly good job. So if it is less than 4 mm, so you can just go for like proximal stripping. This, like, you might have read it in your UG days, like in Balaji, like notebook. So even though like we usually go through the book by name Prophet Williams Prophet, even he suggests the same thing. If at all if the space requirement is 5 to 9, we can attempt a non-extraction and or an extraction depending on the soft tissue or hard tissue. So to in a conclusion, to say the word extraction, clinical assessment is must. You need to see the patient. And then it so happens that in many of my clinics where I visit, the patient, like, just I've been thrown off, like they'll just forward me their OPGs and they ask me, suggest me the treatment plan, sir. I'm like, what? How can I suggest the treatment plan without even seeing the patient? So it is like, and then they ask me, sir, whether this patient will go for an extraction or expansion. No, this is really very difficult for us to say whether the patient goes for an extraction or an expansion. And for non-extraction procedures, it can be like if the space requirement is about 5 to 9 mm, you can think of transverse expansion or distalization of the molar. Distalization is like you are moving the molars backwards, that is posteriorly distalizing it. If at all, if the space requirement is 10 mm or more, directly go for an extraction. So no expansion will help you out in this regard. So while extracting the teeth, the most commonest among them is the all fours, or sometimes upper fours, or sometimes single tooth, single teeth extraction, depending on the requirement. Or sometimes, like if especially if the space requirement is just about 5 to 9 mm, we might go for an extraction of the lower incisors. And then sometimes we go for an upper fives, and one side we are going with an upper force in the upper force and lower I mean upper force and lower fives to get a good occlusion if it is in a class 2 cases. So the contemporary extraction guidelines as such should be that the more expansion without moving the incisor forward and more closure of extraction spaces without retracting the incisor results in satisfactory treatment. The more expansion without incisors forward, just this is an important point. More expansion without getting the incisor forward and more closure of extraction spaces without over retracting incisors results in a satisfactory treatment. Whereas excessive expansion increases the risk of a mucogingival problem. Whereas expansion or an extraction makes no difference at all. There are studies that like by expanding it, our arch might gets collapsed. Or there were studies saying that by expanding it, we might increase the airway space. Yes, we might increase the spaces, but it's no conclusive this thing like this happens or that, like masticatory function might get hampered by extraction. No, so either of this has got no difference. So but it is for sure that by expansion you might develop a mucogingival problems, and the presence of protrusion along with the crowding complicates the extraction distance. Imagine if there is a protrusion and then there is an extra and there is a crowding, and then it's like the orthodontist will be in dilemma. In these cases, we do something called as therapeutic extraction. What we do is we just increases. We start with the case with a expansion. We strap up the case with for an expansion, and we make sure that like if at all if there is a requirement, then we go for an extraction case. So it's always in my practice. I make sure that if it is a straightforward case of an extraction, we directly say yes. This will go for an extraction. If at all, if you are in a confusion, or if you find that like it is a borderline case for an extraction or expansion, it's always better to venture yourself in an expansion. And if you find that there is a more of flaring up, and then overall facial form, facial aesthetic is getting hampered, and patient is unable to close her mouth, yes, then think of an expansion and retracting it. So my orthodontist friend might object this, like, why is that you are doing a round tripping? First you're expanding it. Yes, sometimes it is better to play rather than venturing yourself into it. It is better to play if the patient is is a teenager. It is better to play if the patient is less than 15 years. Yes, because we don't know how the teeth the patient's facial growth is going to happen over a period of time. So always I suggest if it is in a borderline case, always go for an expansion first, and then if at all if it needs to be, go for an extraction. So as a general rule, lips will move two-thirds of the distance of the incisors tracted. Okay, no, I'll be telling you brief of my cases. It's just to, it's not like like to blow my trumpet, like I've done good enough of. I mean, like I do all these cases or something like that. No, it is just to highlight what all you need to see. I'm still a learner. I'm like learning with my mistakes on, with my peer groups, with my seniors at my guidance and help. And then with this, like I'm showing few of my cases. The first case which I'm going to show you, this patient came with a complaint of, like what the patient, what she said was, doctor, my teeth are rabbit-like appearance. It gives me a rabbit-like appearance. I've been getting bullied because of this. And she was just 12 years complete. All her premolars have erupted. And what do you in this case? So I cannot say no, your facial growth will help you out in future, and then you'll have an increased mandibular height, so don't worry. No, the patient main complaint is front tooth teeth. What she said, kindly extract my teeth and then do something so that like I should not get this kind of appearance. So by looking at the patient, I mean, that is the primary concern. As I said, like the patient, whatever they demand is the primary thing. Now, the next thing what I'm going to look is, she has got a class 2 molar relationship. She has got a highly placed canine. Her overjet is almost about 12 to 10 to 12 mm. She has got alignment issues, and because of that, and she has got a lip trap. That is, the lower lip is getting trapped by her two incisors, and somewhat like the I haven't taken the proper photo. Somewhat her face is somewhat concave. That is class 2 profile. So what I did was, first thing is, like, we went directly with the twin block. Twin block is basically a functional appliance which actually helps in getting your mandible forward. So thereby it helps in the passive. It also helps in the passive eruption of the remnant teeth. So by doing that, this patient was carried out under two phases. First, we did a twin block where we got her jaw forward. I'm sorry, like I don't have the after twin block photos. I could have shown you. Then once like we have got her jaw forwarded, then we went with an alignment. So this is how she was after completion of her treatment with the phase 2 with the with the twin block along with the braces. So you can see that midlines are matching, and you can see that she has got a consonant smile, and her lips are fairly resting on her incisors, and you can see that molar relationship also, alhamdulillah, like slightly like it is in class 1, and arch size got well developed, and then it was fairly good. So to carry message from these cases are, like, these cases had to be dealt under two phases. First thing is, like, we had to get her jaw forward. So once we got the jaw forward, then we started aligning all her teeth. Okay, so then once the alignment is done, then this is how she was. and like after completing her 2 years, 3 months of treatment. So this is pre and post. This is like you can see that the lower incisor show wasn't at all like satisfactory. It wasn't visible. Like you can see that the lower incisor show is fairly good, and then occlusion is it got well settled. All by His grace. It is like my efforts are minimal. If it's all by it's Almighty's grace, I could able to do some justice to this patient. And then you can see that like almost straight a profile, a profile also got improved. And then the best part was, since she was 12 years, it was a pivotal age. And then a lower antefacial height also got improvised, that is the lower face, I mean the mandibular growth also happened, late mandibular growth. As a result, everything, like I don't see to talk about this, like twin block doesn't grow the mandible, it just positions the mandible. For your information, it is like the innate potential within the patient that actually makes mandible grow. Okay, so we are just guiding it. It is all by it is the growth which is there in him that actually favored in this patient. Similarly, this patient in her, it's an adult patient. She came with the complaint of, doctor, do something, get one tooth attached in this area. It doesn't give me, like I'm not confident in smiling it. So that was a main concern. Midline diastema was a concern. So when I saw, like when I examined, her lower and anterior teeth were impinging her soft tissues. Okay, and then along with that, like bite wasn't good. Sorry, I did not get her OPG. Like because of that, she was about to get a TMD problems. And then this thing also, she had like teeth were not well aligned. So and then there was a spacing, but this looks like a fairly easy case for us. Like just midline diastema, you close it. No, to close a midline diastema also, you need to not all. Every case is a different. Not no orthodontist can say that this is a simple, straightforward case. Like it gets over like this. No, every case is different. So in this case, for me, it became much easier because she had a proclination as well as she had a spacing. Along with that, she had a lower crowding. I mean, lower spacing as well. This favored her for a better aesthetics, and I was very confident. Like we can give her good result. So what we did there, like almost like about 7 mm of spacing was there in her, and then lower spacing was also there. So we retracted and we closed the space, and this is how we completed her treatment within 1 year, 4 months probably. Yes, and there was no proximal stripping done. These teeth were apparently mobile, like lower anterior teeth were mobile. You can see the gingival health of this lower incisors. Fairly, this case went on good, and then like occlusion also got well settled. Like like she was able to chew her food properly. And then she came for a replacement of one more teeth, but like and then looking at her age and all, like to talk about orthodontic is like you are you need to be a good counselor. But all thanks to the patient that she was able to comprehend what I was able to say. I was with the hope, each and every patient, you should like you should not be like "Nahi naiba nahi sunta." No, he won't listen to my talk. It's like she's elderly, she is old, she is this, they won't able to afford. No, make sure that whatever you speak to the patient, speak with heart out, speak what is there at the present, speak with the literature at your back, speak with like what is right for the patient. It is up to the patient to accept it or not. You clear with the clear intention, if you speak no, yes, patient will fall for it. Patient came with the replacement for for this, she wanted a bridge, but I just like spoke to the patient for for an orthodontic braces. Though her two daughters are my own patients. In spite of that, she got herself, made her mind, and they and treatment came out, pretty good. So this is how it is. Now, this third case, that was the first was, I mean, the first case I showed you about my, I mean, the young patient. The second patient is an adult case. And third case, which I'm going to show, is an interdependency. Like, it's not orthodontics itself is everything. It requires adjuvant treatment. It requires prosthodontic makeup. It requires a restorative dentist. It requires periodontal help. Periodontist help. So many things are involved. This patient, she is from all the way. She contacted us. She came, with a deep bite. She said, like, I have a spacing in between the teeth, and I have got only few months, and I'm flying to Germany. Austria for a further study for an MS. She's an engineer by profession. So she said, like, I need this space to be closed, and then I've got only a few days of time. So when we look at this teeth, she had hypodontia with respect to lateral incisor. Look at the shape of this two. I mean, this both this 1 2 and 2 2, and this doesn't come under golden proportion. So what we need to do? First thing is, like, and deep bite. It's not like a deep bite; it's a traumatic bite. Her lower incisor was not at all very prominent. So, and her smile is like a gummy smile. Can you see the gumminess which is seen? So what we did was, like, since like shortage of time, we gave her an option for an alignment, which she readily accepted. So we went ahead with the treatment. She came. I usually practice Invisalign among all the aligners, and it's not the right forum to say which brand is good, this and all, because, like, I felt like I'm little bit confident with that type of aligners. So we went ahead with the 14 set of aligners. We were able to achieve, correct her deep bite and close all the spaces, no extraction. And believe me or not, we completed our treatment in 3 months, 16 days. That is with the set of 14 aligners. But this is not the end of it. Like, we went ahead with the gingivoplasty. Okay, I can show you in the pre and post op. Like, we went ahead with the gingivoplasty. We went ahead with the restoration to get good proportionate teeth, and then finally retainers. So, like, it is really mandatory to take a help of all this. Imagine if I had closed all the spaces, if I hadn't taken the help of a restorative dentist, or if I had not done some composite buildup, this case could have been screwed up. It couldn't have given a pleasant smile like what she is spotting on. So she was very much thrilled and excited to look out for this midline, like whatever the midline deviation was there, that also got corrected, and then occlusion got settled down beautifully, and then she has got well aligned arches. So, and then time frame was also less. So this was, we were able to do her treatment within 3.5 months. So it is not just if orthodontic treatment, like, you have to do it in like 1.5 years, 2 years. No. There are fewer options, fewer conditions. We can complete within 3 months to 4 months as well. So next, coming to another case that was more of the cosmetics and then adults and all this. This is like a syndrome case. This is a patient. It's not a syndrome. It's a cleft lip and palate case. I do have the syndrome cases, but I haven't completed, and I could because it could have become more. So I haven't taken into consideration. So this patient came with came for an alignment. If you look at the alignment, like, his arches were completely, like, you can see it's out of form. It's not at all in shape, and he had a crossbite, and then few teeth were in crossbite, and his few of his middle teeth were impacted. The deciduous teeth were impacted, and then he had a supplemental tooth as well. So basically, he is a man from a small town village, a small village. So, like, he wanted, and already he had got his primary closure, secondary closures, and all cosmetic surgeries done. So sorry, not cosmetic, the alveolar bone surgeries, along with that, the lip surgeries, everything was done. Now it is just a teeth alignment which had to be carried out in this patient. So finally, we went ahead, like, with the braces. We expanded. I didn't expand because there was a. I was doubtful whether, like, if premaxilla areas comes out or not. So we directly, gave the braces, and he was most irregularly irregular patient. So he used to come once in 4 months and all that. Still, like, I haven't debonded. So this case. So, but it came out nice. like a patient was very much excited to see his treatment on, and then we aligned and leveled all his arches. We could have done more justice to the patient by closing all the spaces, which like inshallah over a period of time we will able to. So this is how the pre and post like patient was not at all ready to accept that his condition was like this when I showed him the pre-op photos. It's all by his grace I could able to do some justice to this patient. Next comes to next case is like like multidisciplinary approach. This patient, this gentleman is like a managing director in one of the firms. I mean, like he's a CA by profession. He came with a complaint of spacing between the teeth. So that was his complaint. So next thing he asked us like do something like all the spaces should close. So and then periodontally, if you see it on examination, we saw that like his 3-1 was grade 2 mobile. We can see so much of recession, and then not grade 2 or grade 2, grade 1 mobile. And along with this, because of the trauma, because central incisors was constantly hitting the lower incisors, they were in bad shape. And unfortunately, his lateral incisors were also missing, and it was uniform space, and his tongue was big and large. And because of the macroglossia, it was pushing. All teeth were getting pushed, so they're pushing his teeth, and as a result, he got a generalized spacing in all the direction. So his next thing was, doctor, my marriage is in 3 months. You need to do something for it. And then like within 3 months, like you can just give a treatment plan of doing correcting social six, giving bridge from 3 to 3, and then doing prosthetic rehabilitation from upper and lower 3 to 3, like I mean 60 social 6. But patient was not ready for this. He wants something the concrete in a lesser time, and then uh, more of physiology rather than drilling, grilling, and all that. Is doesn't work. So he like these kind of patients are usually well informed, and then they because of all thanks to Google and Wikipedia. So all and they they could have visited multiple setups, but whatever we offered them like was like we said like you have a two treatment options. One is short term goals and instant result, and long term goals like I mean the with the longer I mean you'll have a good result physiologic teeth movement happening in it, but on a longer duration. So our treatment plan was to close the central incisor, create enough spaces, and then close all the spaces. But the catch was his marriage in 3 months. What to go, how to go about it. So then we gave him an option of an Invisalign. So like patient went on, like he accepted. Like yes, I'll go for an Invisalign. I had to counsel the patient. Like like we'll create an abutment over here where we'll pull the composite material, and apparently that space will get closed, and like you can wear this on your wedding day. So that's what he did. So patient wore his aligners on his wedding day, and nobody made it out that he was on his aligners. So all these spaces, like we completed, this spaces got closed after 6 months, but after 3 months there was enough spacing. Still there was enough spacing. It wasn't 6 months; it was 8 months to be precise. 26 plus additional aligners. So like there was enough spaces between that. In spite of that, like patient wore the aligners and nobody noticed it. So like his and the marriage also happened unhindered and like uneventful, and then with all happy thing and all that. So like after this is what next. Now how are you going to close this space? Like we gave him option of a Maryland bridge, like where like from inside we can just place it with the help of an canine or an incisor both the sides. But that also like like it is doubtful. Imagine like if it comes out or something like that. So then we gave him an option of an implant, which patient readily accepted. So after closure, and now for me the problem is like once we have loaded the implant, then to place the cap is also an issue. So we are going to place it after osseointegration and then temporary clamp. So what we did was immediate after like he finished his treatment. We placed just an retainer, fixed retainer with just two teeth, with the Essex retainer with this tooth on, and placed an implant. And this is how he was after completion of his 1.5 year of treatment. So this space, can you see, it's like, I could have closed it much better, but since the already, this is like, like my retainer got broke, and then this again, because of that, some space was there. Like you can see that after completion, this space was not at all visible. So like, and the patient did not turn up. So that's the result. We can see that some amount of black triangle. Otherwise, this case turned out to be very beautiful, and patient was very much happy with the given thing. So this is how it is, and then comparison of pre and post. This thing, like, fairly good. Like occlusion, and then aesthetically also very pleasant for the patient. So we were like, like, I'm really fortunate enough, like I was a part of his transformation journey. So in the nutshell, like this case scenario, like what I mean, case series which I showed you, is basically like, to just to highlight that, like, to know what the actual problem is. If you know the problem, you'll know the solution. So as a general dentist, like you can, like, pinpoint them. You can just take it out, and then, like, as and when you pick it up the things, it becomes much easier to translate to the patient. You can say what the thing which you want to say. You can give the different treatment options. So this is how it is. So this is how my this is what I wanted to highlight upon, and signing off. And that's the end of my presentation. Thanks each and everyone for hearing me out. Thank you, Manana.
It was a wonderful session, Dr. Mueez. Really, thanks for giving us your precious time.
Thank you.
If you have any doubts, you can just ask. Dr. Mueez is open. In fact, if they have any doubts, they will just write it in the chat. So we have a question over here. One of the participant has asked that, if a patient is pregnant and wants ortho treatment, how to go about, and then if yes, how to go about, and then what will you do with the OPG? How will you go about the radiographic assessment?
First and foremost, it is always better. There is as such no contraindication if, like, if there is a pregnancy and the braces treatment or an orthodontic treatment, you can go ahead. Like when coming to the OPG, it is always, like, better if you push, like, if OPG, it is better if you don't take the OPG. So if patient has conceived it, and then if they're shooting an X-rays, then it is not advisable. Like before we in hand, if we have the OPG, and then, like, if you're planning out the treatment and to carrying out the braces treatment or an alignment treatment, then absolutely no issue.
Okay. So any doubts? Participants, any doubts you have? Yeah, just I have a small doubt.
Yeah,
okay.
Please.
You were just talking about soft tissue profile and other things. In case if you want to attain root parallelism, any this one, for example, if you want to get a exact parallel root, any clinical tips would you like to share? Because post completion, sometimes you don't get the panoramic radiograph shows a little bit of this one. So in case if you want to get exact root parallelism, what are the tips?
So yeah, first and foremost, it starts from the day you are strapping up the case. When you're placing your bracket is important. So as and when you place the bracket, if at all, if you have like, there's a reason, like OPG role is like important in this regard. So if you have an OPG with you, you can see the roots. You'll know exact position where to place the bracket, and then that shouldn't be a problem at all. And in spite of this, especially during retraction, it so happens that if you're using more forces, or if you are trying to retract the teeth on a round wire, there are chances that the root parallelism, like you might land up in a lateral open bite or something of that type. So in these cases, like you have to stage your treatment. Do go for, like, it should not be like just for the like completion of the treatment, you're retracting with the help of elastics or something, giving heavy forces on a round wire. It shouldn't be like that. So slowly, from the round wire, please then enter into a rectangular wire, then a stiffer wire, SS wires, and on stiffer wires, use the hooks, so that you are able to reach out that, like you have the center of resistance of that canine or the anterior segment, so that retraction becomes much easier. By doing all these smaller things, it becomes much easier. And in sometimes, in non-extraction type of cases, some root parallelism also can be done with the help of wires, by incorporating the bends in the wires. That is, artistic bends, where torque in, torque out, in and out bends, mesial bends, and all that, like you can do it. And in fewer cases, like if you're not well versed with the bending of wires or something like that, you need to change the position of the bracket. By achieving all this, you are more likely that your root parallelism will be achieved.
Yeah. If I can interrupt, can you stop sharing your slides, Dr. Mueez?
Okay.
Yeah. So that we could have a better view of both of you. Yeah.
Okay, done. Is it still visible?
Yes.
I mean,
Slides are not visible. Yeah.
Okay, fine.
Okay. Any doubts?
Assalamu alaikum, doctor. Can you hear me?
Yeah, please, I can hear you.
This is Dr. Barira. A very nice presentation, Dr. Mueez. I wanted
Thank you,
to ask
doctor.
you.
Thank you. Oh, even orthodontist is here. Wow, nice. Yeah.
I'm talking from Qatar.
Yeah, I know.
Yes, I wanted to ask you doubts regarding the cleft case.
Yes, ma'am.
Yes, so during the retraction phase, did you do any gingival surgeries for him? Because during retraction, there would be some bulbous amount of gingival portion.
No, it is a straightforward case, ma'am. I didn't do anything as such. Like, I directly bond
Did
it
you
and
have
strap
any
it.
resistance while space closure?
No, the bone itself will be so spongy that, like, you just strap up, and then you just leave it for. Don't do anything. Don't keep on changing the wires. Like
Okay.
I have on a
Can
frequent
you
basis.
mention the stages of wire you have used in the cleft case?
In this case, like, I started with O12, O14. I started with the least wire. O12, O14, O16, then 1622, then 1725, and normal sequence now. 1725, and then finally
So you used
1925.
all night-eye wires itself.
Yeah. With normal night wire itself, like, we were able to achieve the good arch formation.
Okay. So he did not complain of any difficulty during eating?
No. He was very much comfortable. Like, whatever the forces which we introduced was like very minimal. By the time I entered into rectangular wire, patient was already toned for it. Like, he didn't have any issues at all. And then slowly we incorporated, right?
Okay. And regarding the last case, the male case, the wedding case, to be
Yeah.
precise. So, when did you decide the abutment in the Invisalign treatment protocol? Like you decided before itself?
Yeah. We decided before, like, we had, like, already, during submission of the treatment plan, we had mentioned that, like, abutment has to be placed with white composites. So it was like in the initial itself, it was decided now.
Okay. How did you convince the patient for implant later? Because Invisalign itself is a big amount to pay. So did you explain about the implant earlier
Yeah,
itself?
we had told him. Like, he
Okay.
was well informed, and then it wasn't easy for us to go for a higher treatment. This comes under the comprehensive package along with that implant and all that.
Yes, so
But
you took the
he was
comprehensive
aware of all the
Invisalign
things.
package.
Yeah.
You took the comprehensive Invisalign package.
Yeah, especially in this, we should not venture into light or moderate package. You have to play very
Uh-huh.
safely because we don't know, like his periodontal condition is like very
True,
bad.
true.
And if at all, if it so happens that, if tooth starts turning mobile, I have to increase the number of aligners, or probably duration of aligners needs to be increased. So in that way, like it's always better if there is any periodontally compromised case, play safely, go with a increased number of aligners or increase the wear time. So in that
So
way,
he used to change the aligners weekly, or like you extended
like
the time because
no,
less forces could be applied?
like we suggested him to wait 7 days, 7 days.
Okay,
Like I
every
did not
7 days change. Okay.
7 days change.
Okay, okay. So usually in the adult cases, if such cases of periodontal compromise cases are there, we strap up usually arch-wise, like first the upper arch or the lower arch, so that
Hmm.
the load is less. So
Hmm.
did you put the both the what you say
No,
aligners
since
together?
since the splint effect was there with the help with the aligners on,
Mm-hmm.
so like
Mm-hmm.
it was much easier for us to go with
Both the
go
arches
to
together.
incorporate the feature for both the arches, rather than
Okay.
like waiting and then doing that. And then
Mm-hmm.
I could have landed in a class 3 tendency because already the H to H bite was there.
Yeah, yeah.
Yeah, so like we had to incorporate for both the arches.
Oh, okay, okay. Because usually in colleges we were taught not to do both arches together.
Yes, ma'am.
So,
But here, like it is
mm,
completely digital, and then
okay,
mm,
okay,
so like we
okay,
had an
okay.
upper hand there.
Okay. And in the first case wherein you had an expansion, the baby girl, how old was she when you started the twin block?
12 years, 12 years.
So did you do any expansion in that or just the
No,
normal
I
twin block?
incorporated the expansion features
Okay,
along with. If you had seen her palette, it was looking fairly expanded one.
okay.
With an
So
expansion, we went with the twin block.
you incorporated Hyrax in the
Yes,
twin
yes.
block?
We incorporated a high racks along with the
Okay,
twin block.
okay, okay. Thank you so much, Dr. Mueez, for
Thank you,
patiently
thank you,
answering.
thank you,
Thank you.
thank you, thank you.
Any doubts? Thanks, Dr. Barira, for getting involved and asking questions. Okay.
Yes, now our juniors are our professors. So we, because they are so well versed with the latest technologies and techniques. Every time, ortho is always changing. So
Exactly.
same, the same book treatment might not work. They have new techniques to, handle cases. So we learn a lot from our juniors.
Yes.
Not really, I'm not really still learning in phase.
Anyways, it was a
Thank you, ma'am.
wonderful
Thank you.
session, Dr. Mueez. I don't think anybody has any questions. You can just post it. Dr. Gausia?
Nothing from my side, doctor, because I am into interceptive, so I could learn a lot of it from Dr. Mueez, especially the twin blocks. Yes, and then yeah, when a periodontist does interceptive, we always bank upon the orthodontist to take over. So it would be always grateful to have a good orthodontist, cooperative orthodontist along with this. So yes, I did see a good collaboration.
Thank you, ma'am.
In the end, I would like to thank Dr. Gausia and members of GDP for giving us an opportunity to speak on this session. Thank you, Dr. Gausia. I really appreciate your efforts and this. Thanks once again.
Thank you, Vananath, for an opportunity for all this. And thank you, ma'am. Thank you, Junaid, for an excellent moderation.
Thanks.
Okay, let us sign out. Okay.